Hi everyone, Chris Ng here, and this is another adjunct video trying to connect what you've learned about maternal physiology with advanced cardiovascular life support. Many of you guys come from a healthcare background, and most of you guys are familiar with basic life support and resuscitation. And moving on to step further is advanced cardiovascular life support. So this is trying to show why it's important to understand some of these changes and how they affect other specialties. So first thing we're going to talk about is cardiovascular changes. So cardiac output. So cardiac output is how fast the heart is beating as well as how much blood is pushed out with each ejection. And one of the most common symptoms you'll see in pregnancy is aortal cable compression syndrome. So this is where a lady lies on her back and she starts feeling dizzy and short of breath. Here's an excellent image. You can see when someone's lying down completely flat, you can see that the aorta and the vena cava are completely compressed. And this is going to decrease venous return from the lower extremities, and this is going to decrease your stroke volume. And one of the common questions I get from lots of pregnant moms is that you cannot hurt your baby by lying on your back. People often go to bed and they find themselves waking up on their back. What will happen actually is the mom will actually feel short of breath and will wake up gasping for air. And if you think back to your physiology lecture, we know that babies get a preferential access to the oxygen that's carried in the bloodstream. So how does this change your resuscitation? So these are recommendations from the American Heart Association that basically determine the ACLS protocols. So basically their recommendation is that continuous manual left uterine displacement should be performed on all pregnant women. So you can see an excellent picture of a gentleman pushing against the uterus to help deviate that uterus off the vena cava. So really we should be doing this for anybody who's at the umbilicus, which you remember is going to be 20 weeks, and this will help improve the resuscitation. If you do not have access in the community for BLS, they do recommend that you keep the patient in left lateral decubitus position, so off to one side, and again to help improve that circulation. In a hospital setting where you've got lots of hands and a big team, we actually prefer just doing left uterine displacement because it doesn't disrupt the ability to do chest compressions or intubate. It's very hard when you're tilted off to one side. So the other thing is we talked about how venous return from the lower extremities is basically gone due to this gravid uterus. So they do recommend that any IV access should be established above the diaphragm, so to ensure that your ACLS drugs like epinephrine are actually delivered to the body. So this makes it harder. For example, interosseous has become a lot more popular. So this does make it harder to achieve good, effective ACLS. Moving on to respiratory changes. So you remember in pregnancy there are increased metabolic demands and the fetus is also consuming that oxygen. So oxygen consumption increases by about 20 to 33%. In addition, due to the rising diaphragm, there's actually less functional residual capacity of the lungs. So this is the air sort of left over in the lungs. And this is sort of your reservoir for oxygen. And this will decrease by about 10 to 25%. So putting these two things together, basically, you're in trouble. Once you lose circulation, you get rapid hypoxemia if you're not ventilating. So that's important to know. So because of that, the American Heart Association recommends that hypoxemia should always be considered a cause for cardiac arrest. Oxygen reserves are lower and metabolic demands are higher compared to non-pregnant people. You should consider early ventilator support. In addition, we should be using 100% oxygen. Try to maximize that oxygen delivery to the mom and fetus as well. And on to my final point, just talking about the uterus. So remember, the uterus itself is a low resistance vessel. The placenta invades and becomes low resistance, and it receives 20% of cardiac output. And this is about 1 liter a minute. So you think about your normal circulating volume being about 5 to 6 liters. You got almost 20% of your circulating volume goes towards the uterus each minute. So again, that makes postpartum hemorrhages very scary. So because the uterus really demands this, we actually recommend a perimortem C-section for every mother in whom return of systemic circulation has not been achieved after 4 minutes. That's crazy. So what they're asking us is that once we lose a pulse, we need to be ready to cut this baby out within 5 minutes. And so if you look at any of your labor floors, every single crash cart is equipped with an emergency C-section kit. So we are all trained and ready to do an emergency C-section if necessary. So that sounds pretty drastic, and it is quite horrifying. But why do we actually do this? So when we actually look at some of the evidence behind it is that we know that when we perform perimortem C-sections during a maternal cardiac arrest, that we often see tremendous improvement of the hemodynamic status or return of systemic circulation after the baby has been delivered. For example, in this case series, they found that 12 out of 20 women who've had a perimortem C-section actually had return of systemic circulation immediately after the C-section was performed. And again, the bottom point is, again, mom and baby are already dead at this point. You have to do something. If you cannot restore blood flow, the inevitable outcome is both will die. So even though it sounds drastic, it is really important. So again, this is the flow sheet that you've often seen with your classes. So again, looking at some of the changes that are adjusted in pregnancy. So again, we're going to provide 100% oxygen and avoid excessive ventilation and sort of push things down. We're going to place an IV above the diaphragm in the upper extremities to ensure that our ACLS drugs will actually go through to reach the patient's heart. We're going to make sure we perform continuous left lateral uterine displacement. And we're going to prepare for an emergency cesarean section within 5 minutes. So those are sort of the changes that are there. So anyways, guys, I hope you learned something and got a sense of why it's actually important to know this lecture about maternal physiology. I'm hoping that you'll be able to take this into your future rotations, even if you're not interested in obstetrics, and go impress your emergency doctors and your internal medicine doctors. Okay, guys, hope you enjoy the rest of the week, and I'll see you guys on Wednesday.